We are beginning the last session of YEARMED 2025, where we'll talk about diabetes and bit of obesity. And we're going to take again 4 to 5 practice changing about, in fact, we have 6 articles today, which we're going to discuss and which have a common theme, as you'll see. These are all going to likely to change your practice. So it's an absolute privilege to have with us our faculty today, Dr. Ipsita Mishra. She's done her MD in Pediatrics and DM in Endocrinology, and she's a senior consultant endocrinologist, and the associate professor and head of department of endocrinology unit at Cuttack, and she's had about 34 publications. She's authored 3 book chapters. She has a deep interest in neuroendocrinology, pediatric endocrine, adrenal metabolic bone diseases, and she's had a distinction holder in MBPS. She was a second runner-up at ESI TISA. Uh, I think I was there that year probably, and she had the best. Yes, yeah, yeah. So best, she had the best original article published in IJEM 2022. I think, and one of the major achievements is in fact, quite a big achievement. She won the Presidential Poster Award at the Endocrine, USA in 2024. So congratulations, Ipsita. And this was again, to kind of have your uh, research being, given acknowledgement at the international stage is a great thing. So welcome, Ipsita, and welcome to our little endeavor. And let's begin. So this is what we're going to discuss today. We'll discuss about some interesting research work done in the field of type 1 diabetes and obesity. We'll discuss about MASLD a little bit because there are 2 important game-changing updates in this field. There's a lot of talk about GLP-1 RA and its risk factors, and we'll discuss one particular one about ischemic optic neuropathy. And finally, we'll end with a common misconception, or rather common problem that we face, that is perioperative use of SGLT2 inhibitors. And we'll discuss some new data, new research on this published in JAMA this year. So this is what we have on our plate today. And let's begin with this topic on type 1 diabetes and obesity, which is very interesting because when we traditionally think about type 1, we don't think about obesity, right? But now with better treatments available for patients with type 1 diabetes, better insulins, their increasing longevity and improving overall well-being, there is now a second problem which is now emerging, which is obesity. So nearly 2/3 of adults with type 1 diabetes have overweight or obesity, which is quite a number. And we all know that insulin does produce weight gain. So that's again an issue. A lot of patients have hypoglycemia and a little bit of defensive eating also. So that also adds to the problem. And a lot of type 1 we know don't achieve glycemic control. We have this emerging terminology of one type 1 diabetes plus, additionally element of insulin resistance, which is now happening. So these are the common issues with type 1. And again, we have current limitations also. So we know that insulin is the treatment for type 1, but then it does produce weight gain. Uh, existing technology that we have, that is CGM and pumps, they address the glycemic control part, but they don't address the weight gain part. And so there are issues. And again, diet and exercise there are restrictions there. Also, exercise can sometimes, induce hypoglycemias, and that's why, often these patients tend to have a little bit of, a bit of defensive eating and all. Now, a common question which has often been asked, and a common issue which arises, is can we use some of the medications which are not dependent on pancreas completely, which are available for type 2 diabetes, can we use them in type 1? Now, this is not the first time this question has been asked, and it's not the first time where people have thought about this. Dr. Ipsita, have you used any non-insulin medications in your type 1 patients over the years?
First of all, I thank Dr. Om for this elaborate introduction, which of course I didn't need. Thank you so much for having me here with you. And I also thank the other organizers involved, especially Lupin, for letting me in. Well, this question is something which is asked to all the trainee when they are in the DM days. What are the non-insulin therapies that can be used in the management of type 1 diabetes? So with overrising prevalence of type 1 diabetes, and as you said, the coexistence of IR with type 1 diabetes. We had heard the term double diabetes, and it is very common these days, especially in the peripubertal years. So
Right.
the most common drug is what we use, and even I also use, especially in those type 1 diabetes where they need very high insulin doses, is we use metformin. So it's
Yes.
kind of a differential insulin resistance which starts behaving in those children, especially during the peripubertal years. So metformin is something which we use. Lot of drugs were proposed long back, starting from DPP-4s, from SGLT2 inhibitors, pramlintide, and the evolution of GLP-1s also came up. But then with time, yes, the benefit of is GLP-1s, we are getting data from various landmark trials which we are going to discuss. And use of GLP-1 came prior use of SEMA with LIRA, but then it was discontinued because of the occurrence of DKA in those group of kids, but it was not causally attributed to the drug per se. So yes, we do use metformin. I have seen prescriptions in type 1 diabetes where they use voglibose also, but voglibose is something which I do not give disaccharidase inhibitors, but metformin, yes. And it is not uncommon for type 1 diabetes females to have coexistence of PCOS also. That also
Right.
we are seeing.
Right, right. Very true, very interesting. And very right that, it's the sometimes the peri-pubertal, just at the onset of puberty, these children with type 1 who are otherwise doing well, suddenly the insulin requirements kind of jumps up, and, the doses become extraordinarily high doses which you'll require to achieve the same glycemic control. And yes, we all use metformin over the years. We have also been using acarbose. You talked about voglibose. In our practice, we use a little bit of acarbose as well. Does help. DPP4, I think probably the effect is modest, but it can reduce glucagon. So my professor used to say that it could potentially reduce risk of episodes of diabetic ketoacidosis, but then there was never proven, and no study was done. For a while, SGLT2 inhibitors were actually being tried, but like you very rightly said, there are concerns with risk of diabetic ketoacidosis. So I then again, SGLT2, there were ons and offs, right? There were periods of time where they were proposed for abuse. There were studies which were done, and then eventually the regulators said no to that. So then comes the question is, the one which we all talk about now is the GLP-1 RA, and can you use GLP-1 RA in type 1 diabetes? And a few years back, there was a small, actually, a letter to editor, which was published in New England Journal of Medicine, which actually was a small study where they use semaglutide in patients with type 1 diabetes and found remarkable results. So I think that did promote an idea that potentially this could be used in type 1, especially type 1 who are obese. Few reasons. One, it will reduce the weight. It will improve to some extent glycemic control, but additionally, it would also give certain other cardiac and renal protection that you get from these groups of drugs. Overall, Dr. Ipsita, what is your preliminary view? Of course, we'll dwell into the data, but your preliminary view on the idea of using GLP-1 RA in type 1 per se, adult type 1 diabetics.
Okay, now in type 1 diabetes, for the understanding, let us try to go to the basics. So, when the
Right.
beta cells are destroyed, but the alpha cells are still preserved, so
Yes.
what happens is hyperglucagonemia still operates in these kids. So now
Hmm.
we need something where we want to suppress the glucagon axis also, because we know that something known as the glucose glucagon axis, it operates in the pancreas, which are very much involved in the regulation of the glycemic parameters. And we have the preservation of another cell entity known as the delta cells, from which something known as somatostatin comes out. So now the
Right.
somatostatin has got a kind of effect on both the alpha and the beta cells. So GLP-1 analogs also have got a kind of inhibition on the somatostatin release, which will lead to a suppression of the glucagon. So this is the basics which gave to the idea for the researchers that yes, GLP-1 analogs can still be used in the autoimmune mediated diabetes by taking care of the glucagon part. So that was probably, I think that was the initiation for to understand how GLP-1 can be used in autoimmune variants.
Yeah, very true. Very interesting. That the alpha cell part is also taken care of here in this is the group of drugs. And just like, we were taught many years back with DP4, and I think, it's an interesting concept in itself to think, so in this, with this regards, we have chosen two articles which are published this year, both of which have actually looked at this in a more closer detail. One looked at semaglutide, the other one looked at tirzepatide. So this is a study which is called the EDGEST T1D trial. It was published in New England Journal of Medicine NEJM Evidence, not the main NEJM. There's another publication called NEJM Evidence, and this was actually one of the authors. The first author is Viral Shah, who has done his DM in endocrine from PGI Chandigarh. Now he's in the US. So a very interesting. Again, it's more of a proof of concept rather than a detailed trial, but it's a very well done study. So this was the first trial where they actually looked at type 1 diabetes, use of semaglutide in type 1 and obese patients. Now, there were 72 adult type 1 diabetic patients who were obese with a BMI more than 30. And they, just like the usual, protocol, they used the diabetic doses of semaglutide. That is, they went up to 1 milligram. Remember, the diabetic doses of semaglutide are 0.255, zero point 0.5, and 1, whereas the higher doses 1.7 and 2.5 are more of obesity doses. So they went to the diabetes doses. They looked at overall. Their idea was to see two things. One is whether there is an improvement in glycemic control in terms of the time in range and other parameters, and second was to see weight loss. So two primary outcomes: composite improvement in more than 70% time in range, and the other time in range parameters, CGM parameters, and more than 5% weight loss. So that is what they're looking at. Interestingly, 36% of the patients in the trial group, they achieved the composite endpoint versus zero in placebo. Again, mainly, of course, you wouldn't find weight loss with the placebo. And as a proof of concept, this turned out to be pretty interesting. I'll just show you a little bit more detail of this trial to before we discuss with Dr. Ipsita. So, like I said, 36% of the patients in the in the drug arm versus achieved the endpoint. That is the two criteria which they put. There was about 8.8 kg weight loss in the in the children who, and it was a placebo controlled trial. So again, we didn't know what arm had what, but in the arm which received semaglutide had about 8.8 kg weight loss, and there was 8.8% improvement in time in range also. So again, there was an improvement in time in range, and of course, the million-dollar question is, what are the risk factors? And there were no diabetic ketoacidosis actually reported in any of the cases, and the insulin dose also reduced by 22 units per day. Right, so this is again remarkable. So, Dr. Ipsita, your preliminary views on this trial. Very well done trial, well conducted, good idea, and well executed, and interesting results. Dr. Ipsita.
Yes, the two important concerns are, of course, decay and severe hypoglycemia. So,
Correct.
this was very nice. I do not know the two episodes of severe hypoglycemia which occurred in those who were taking the drug users, the 36, whether it was, we cannot directly say that it is attributed to the GLP-1 per se. Could be
Correct. Correct.
anything, could be the food habits, could be some exercise habits, could be maybe some overuse of insulin or whatsoever. But
Right.
overall, if you look into this, this is a very promising data. But of course, these patients were on automated devices. So, in for our context, where we know that majority still use MSIs. So, if we
Right.
want to extrapolate this, so at least we can say them that you even, and we know that CGMS devices are also not very used on a very large scale. So still it is the traditional home-based edgetic kind of a monitoring. So of course, if we when we are clinically we are seeing that the patient is needing kind of very large units of insulin, maybe 2 unit per kg more per day. So then we know that it is defined technically as a kind of an insulin resistance, and we
Right.
want to bring it down. We want to extrapolate the benefits of the other cardiocrenal. Now, along with that, we know the component of MASLD is also coexisting in the
Yes.
type 1
Correct.
diabetes patients. So, extrapolate, we can use this molecule, of course, with guidance, very close vigilance and monitoring, where we can no, ask the patients to keep a track and maybe at points reduction of insulin need, which will happen when the weight starts faltering. So I find this is very promising and data. And now we have the other trial that you're going to speak of with Terzapatide. Again, that is also very promising because when we are not getting decay and hypoglycemia, then with vigilance, we can extrapolate these molecules.
Absolutely. So very true. So the, you are getting like she said, Dr. Ipsita said, you'll get the weight loss benefits, slight bit of improvement in glycemic control, but very rightly said, the other benefits, and we, in fact, today we are going to talk about MASLD as well with semaglutide. And there could be potential benefits in these things. Of course, you have to be careful. You'll require, these children will require, or these adults rather, they're, we're taking adults here. These adults will actually require closer monitoring, because again there is risk of hypoglycemia which would be there. And like Dr. Ipsita rightly said, these patients in India might be on multiple doses of insulin, so you have to be even more careful, in these group of patients. But having said that, I think, as an idea, it's an interesting idea, which you need to look at. And there's a similar study, which was done with tirzepatide, and this was published in Diabetes Care very recently, so November 2025. So when I was looking at the semaglutide trial, this actually popped up. I said, why not think about tirzepatide as well? Very similar trial, very interestingly similar group of patients they took. So they took, but the number was small here. So that, the Virals trial actually had more number. This had 24 adults with type 1 diabetes. They took the tirzepatide doses of 2.5 and then extended to 5 milligram versus placebo. It's a 12-week trial. They looked at change in body weight. That was the only endpoint they looked at. They not they, of course, there are secondary endpoints in terms of the glycemic improvement in glycemic control. But basic idea was to look at the weight loss, and they found that there was 8.7 kg greater weight loss versus placebo in this group of patients. Dwelling more deeper into the study, it was done in adults between ages of 18 to 60 with type 1 diabetes more than 2 years and BMI more than 30. And they took 2.5 and 5 mg doses, so they did not further escalate the doses. Versus, again, it's a placebo controlled trial. And most of these patients were on insulin pumps again, or MDI, certain patients here. So there was a mixed crowd here, uh, whereas Viral's trial mainly had patients on pumps. Again, they monitored for the usual parameters, the body weight reduction, HbA1c reduction, the insulin dose requirement reduction, and hypoglycemia and ketoacidosis and GI side effects. So this is the overall trial results. 8.7 kg weight loss, uh, more than almost 100% patients, that is all 24, actually had more than 5% weight loss. And there was 35% reduction in insulin dose, which is again very interesting and very useful. And in a way, if you think, the cost of insulin also comes. Of course, you can't compare it with cost of tirzepatide, but at least there is some saving as well in terms of the cost there as well. Now, one more thing I'd like to add here. Tirzepatide is actually more tricky because previously there are reported episodes of diabetic ketoacidosis with tirzepatide, which are not reported with semaglutide. That is one. Whereas on the semaglutide side, a lot of patients actually have upper GI side effects, and patient have nausea and vomiting. So again, sometimes a bad episode of nausea and vomiting can trigger a decay in some of these patients. So you have to be very careful. In both these groups, these are initial trials, early trials. I would rather say, yes, they are practice changing in a way, but you have to be very careful before you prescribe these agents to your patients. Dr. Ipsita, your views on the tirzepatide angle of this study.
Absolutely, as you rightly quoted now with tirzepatide, the risk of right because of the dual agonistic part, maybe the nausea
Correct.
vomiting part is bit more triggered. So
Right.
and I think this is the going into the phase three. We do not have the data of the phase three, so about this. So maybe the phase three will give us more clues into the occurrence of decay and with this nausea vomiting related part, because I do find in clinical practice after evolution of tirzepatide since last 6 months, there are patients, the type 2 or the individuals with obesity where we are giving tirzepatide as an AOM. Certain patients, they really throw out very bad nausea and vomiting. So
Right. Right.
I mean, it does happen. So I think we should be cautious, and more data, as you said, will give us better answer. Of course, the weight loss part and everything is there, but then that
Yes.
thing is
Absolutely.
still there.
Absolutely. So safety angle and safety first, obviously, right? So end of the day, it's an again interesting proof of concept. Remember, both these trials are recent. Very small numbers have been included, but as a concept, giving these agents in patients with type 1 diabetes is something you should consider. There are definite benefits, and again, we'll be looking at it at this space very closely. And hopefully by the time we have YEARMED 2026, we'll actually probably have more trials in this space, and we'll look at it in a more closer manner and something with a great interest. Uh, so that was
I had one
yes,
more take. It just came into my
yes,
mind, Dr. Om. In these type 1 diabetes, the coexistence of diabetes distress is something which is very high. And
right,
these group of drugs, they are not directly, but the so-called risk of some suicidal tendencies
yeah,
are
yeah,
still, I will not say that it is zero. So that part is also something which needs to be
yes, we
taken
have to
care of
watch
because
for.
mental health is not talked about in this country.
Yes,
That that
yes,
that
you're right.
that part is there.
Absolutely. So I think again, so there'll be a lot of undercurrents to it, right? The mental health part. In fact, you could look at it both ways. There are type 1 who actually have, with obesity, also suffer other issues
Yes,
as well. So I think that
yes,
there's a both way of
yes,
looking at it.
yes,
But
yes.
absolutely, this again, will these are very small studies with very early data. I think we'll probably look at this space more closely. But as a proof of concept, this is something which is definitely worth looking at. Then let's look at the second chapter where we discuss about MSLD, newer developments, and two very interesting developments which are there. Again, as a background, we have discussed MSLD at length on a lot of our previous programs and courses. It's an area of interest for me. But as a baseline, MSLD, if you take just a few years back, there was no treatment for MSLD. The only treatment was weight loss, right? So all you could tell your patient is that, okay, fine, you have fatty liver, you have MSLD, you have, it was called an NAFLD then, or NASH. And if you had these things, all you needed to do was weight loss, and that is all we could kind of offer to you. In India, saroglitazar was, available for treatment, but internationally there was no drug in the US FDA approved until resmetirom came, which again was a game changer in a way. But last year there were two trials published which are very interesting. One ended up getting an approval. The second one, I think, is something which we have been saying for a long, long time. However, now the companies are not very interested, but something which can be considered. So what we're going to do is we're going to look at two drugs which have potential to be used in MSLD. One is the semaglutide, the GLP-1 RA, and the second is very interestingly dapagliflozin. So we'll discuss both of them. Like I said, the problem, with MSLD is it's a huge problem. It's as big as obesity in itself, if you think about it. Again, a lot of our type 2 patients already have MSLD, and they are likely to then progress to develop fibrosis and then end stage liver disease. And right now, globally, the number one reason for liver transplant is actually the NASH related chronic liver disease or the MSLD related chronic liver disease. So that's something which is now a very important area. Dr. Ipsita, what's your, before we go to the specific trials, what's your current therapeutic, approach to a patient with MSLD?
So, therapeutic approach is the traditional thinking that the quantification of steatosis done by the ultrasound corresponds to the LFT. That traditional thinking, it should not happen. That is the first thing, because presence of fibrosis in vivo with the LFTs being normal is quite common in MASLD. Still,
Right.
many non-invasive and invasive methods came up for screening of MASLD, but then that exploitation is not very much in our clinical practice. So even if it is steatosis and the radiologist write mild hepatomegaly or grade 1, I don't know what is that grade, but they write it, and the patients are like, it's just mild and every Indian has that. But when beyond that, nobody goes deep into that. That is something which the approach we need to do. And the basic non-invasive, FIB4, which can be used where you just need four things, and it has got a very good negative predictive value. So if
Yes.
there's a screening has got a good negative predictive value, at least then you have something where you need to further worry or not worry. Yes, and then probably you will take up questions and we'll discuss more about how we are going
Yes,
to go deep into the reaching a diagnostic strategy. Therapeutic modality, yes, as weight loss is there, but saroglitazole does not give us promising results, even if it is. If F1, I never find if it is going down below or anything is returning back. So I have never got any good data. But now with evolution of these molecules and related to the SGLT2 inhibitors, 4 5 years back, it was spoken by Amrish sir, and he had a paper published also where MRS
ELEF
did
trial.
find
Yes,
good improvement with SGLT2 inhibitors, but then they were only spoken up for the cardiac, the renal part, and now they are speaking in terms of the metabolic part more. So it is not new with SGLT2 inhibitors, it came up, so it's not by the weight loss, but by the other pleiotropic mechanisms where it kind of changes the liver fat content. So this is what, and then we will take up with the other, I mean, GLP-1 analogs, of course, they are game
yes.
changers.
Yeah, absolutely. So very rightly said. So I think it's an area where we are evolving into it. We are our understanding is actually improving. Now, what has happened is for a long time, the issue with MSLD is that uh, to really get the approval of US FDA, you actually require a trial where you actually done the liver biopsies and then proven that you are actually preventing the liver fibrosis from progressing. But that is one of the major roadblocks for a lot of these drug companies to really take this as a challenge, because getting people who are otherwise not having existing liver disease to be agreeing to do liver biopsies is a very complicated and challenging process. And liver biopsy is not as simple as a lot of the other modalities of investigation. So I think that has always been a challenge in terms of developing therapeutics for MSLD. Before here we had one more drug which was already there, which has been talked a lot about, is pioglitazone, right? Pioglitazone has always been around for MSLD with type 2 diabetes, right? But then you couldn't extrapolate that to non-diabetic individuals. And again, we all know pioglitazone has its own other subsets of side effects, which it's much known about. Now, then, so I think again a very important trial which came about was the Essence trial. Again, Dr. Sanyal, yet another Indian involved, and I think we should be proud of it. The Essence trial was published again in New England Journal of Medicine in October 2025, which is one of the largest trial which looked at the use of semaglutide in MSLD. So the first large trial of GLP-1 RA specifically in this group. And why this is very important is because they actually did biopsies in these patients. So it was 800 plus patients with biopsy proven MASH and fibrosis, and they did serial biopsies of these patients on follow-up as well. And ultimately, they increased the dose of semaglutide and went to the obesity doses, that is 2.4 milligram versus placebo, which was given for 72 weeks. And the outcome was to look at resolution of MASH without worsening of fibrosis on biopsy, right? Which is again, I'm stressing that that's why this is an important trial. And 63% of the patient, if you see the trial results, achieved MASH resolution, which is remarkable, versus 18% with placebo. And why this is important? Because for the first time, you had actually have medication which showed resolution of steatohepatitis in large number of patients. Resmetirom also had good results, but again, resmetirom, here the numbers are quite staggering. And again, looking at more depths of the trial, semaglutide, like I said, was gradually titrated up like in the usual protocol. They did they did the liver biopsies at baseline, and then at 72 weeks they did, and they also monitored the other parameters like the liver enzymes, weight, metabolic parameters, and so on. And they wanted to look at the MASH resolution, and this was the result. So 63% had MASH resolution, and 37% had fibrosis improvement also on biopsies, and 13% was an average weight loss in these patients. And if you see the softer parameters, the SGPT normalized in 70% of patients. Again, more people who had more weight loss had benefit, and both diabetic and non-diabetic patients actually benefited. So this is not done in diabetic alone. This was done in all MASH patients, and it was GI side effects were there, but of course did not deter patients in a sense overall in terms of the course of treatment. Dr. Ipsita, your views on this very interesting study.
Yes, now Resmetirom was a game changer 2024, but then it was with
Yeah.
MASH plus fibrosis minus
Yes,
cirrhosis. So
correct.
GLP-1 analogs in this trial, they included MASH with fibrosis minus cirrhosis, but again GLP-1, there are small data with MASH plus fibrosis plus cirrhosis.
Yes.
So definitely data is good, but one thing, because today I faced a patient who has got MASH plus fibrosis plus cirrhosis, but the BMI is something what most of the patients in this trial, they had an average BMI of 34.5 kg per meter square. So
Hmm.
there you face the problem, because the patient who came to me today had a BMI of 23.4. So
Right.
in this group of category of patients, and it is MASH plus fibrosis plus cirrhosis, so I
Hmm.
cannot use resmetirom. Then
Right.
what about, I mean, the gastroenterologist had himself written that, ask the endocrinologist to give you GLP-1 with SEMA. So I very skeptically I have did started, and I have told that I'll see how your weight is going, and then you have to look into the associated comorbidities if the patient is diabetic. Non-diabetic
Right.
part, okay, fine, but MASH per se can lead to other renal complications even if it is a non-diabetic individual. So yes, the data is
Yeah.
good. Definitely with fibrosis there is reversal to the tune of around 60%. But then the weight part, as the patient that I face today, there you maybe, I don't know how it's going to happen.
Yeah, very, very interesting and very pertinent point. So you're very right. In fact, this trial was basically done in obese MASH patients. So that is again something which is a very important point you raised, because that has to be very clear that it was obese patients with MASH. That is one. Secondly, very rightly said, these patients are they're excluding patients with chronic with established fibrosis and cirrhosis, right? So these patients, in a cirrhotic stage, you are not, they're not going to be included in these trials. So these are all patients who are before that stage. In fact, now, interestingly, Dr. Ipsita, resmetirom people are actually doing a trial in established
With
cirrhosis also.
cirrhosis.
So,
Right,
so they
right,
are
right.
doing that trial because I think, they had some early signs in their earlier trial, and I think they are looking at it in a more detailed manner. In
Right.
fact, very interestingly, let me tell you, just a few days back, we were having lunch with our gastros, and one thing they said that when they were residents in hepatology and gastroenterology, they are always taught that fibrosis once established is irreversible, which is not true. Which is very interesting because now that is in hepatology field, that concept has completely changed. That the fibrosis can be reversed. Only thing is you need the right strategy for that. So I think it's a very interesting area of development, and you're right that a non-obese uh, MSLD cirrhotic patient, probably you will be very careful of giving this drug because you don't know the results there. But for obese MSLD, especially with diabetes, this becomes a very it becomes in fact very important that you use that because you don't have many options to really offer to them apart from that, and we know that it does progress very pertinently. And then in a similar light, and this is where Dr. Ipsita talked about the trial which Dr. Ambrish Mittal and the group had done from Medanta, which was called the E-Lift trial. Uh, this was one of my favorite trials. Again, I still remember, reading a lot about it during that time. Uh, Reason why, again, in a sense, personal to me also, Dr. Shafi, the first author there, was a close friend of mine, is a close friend of mine, and a very interesting concept which they came up with. And Dr. Shafi actually, this they were invited to as a for to give a talk on this topic at diabetes, the international conferences of the ADA. I think back in 2023 or 22, I don't remember. But so initially, SGLT2 inhibitors were definitely thought as an important class of drug in potentially use in MSLD. The problem, why Dr. Ipsita very rightly said, is that their focus shifted towards kidney and heart and other areas where and eventually allow a lot of these drugs that are off patent. So now the companies are not that interested in doing new trials on this. So that concept of using SGLT2 for MASH got left behind. When a few months back, we actually had a similar forum where we discussed this with Safi himself, and he said that one paper has come across to me, as I'm a reviewer. I don't know if I should be saying that. He said that, but it's from China, and they're looking at dapagliflozin, and they've actually done liver biopsies in that patient, and they've actually found good result. And in a few months down the line, I actually saw this paper being published in BMJ. And then I sent the paper to him saying that, was this the one you're talking about? He said yes. So this is a paper which is called the Dean trial, which is published in British Medical Journal in June 2025. It's a first large RCT of SGLT use in with MASH. Now, there are earlier trials, including ELIFT trial, where they looked at softer endpoints like the MRI and MR elastography. Here, they've actually taken biopsies, right? So they took 154 patients with biopsy-proven MASH, with or without type 2 diabetes. Again, interesting, because most of the other trials were diabetic patients with MASH. Here, they took with or without diabetes. They gave them DEPA versus placebo for 48 weeks. Again, they looked at MASH improvement without worsening of fibrosis, and 53% achieved primary endpoint versus 30% in placebo. Okay, so interesting. And why this is important? Because the first time you have actually have SGLT2 inhibitor trial showing both MASH resolution and fibrosis improvement with histological confirmation done in biopsy, and plus both diabetic and non-diabetic patient. Dr. Ipsita, your initial views on this trial? And I'll tell you what, semaglutide everybody cannot afford right now, right? But
Yes.
dapagliflozin or empagliflozin, most people can afford now, right?
Right, right,
So yeah,
right.
yeah.
So
So your
definitely,
views on that one?
I mean, SARS paper 5, 6 years down the pipeline, it had showed the same thing. But yes, we got the extrapolation in terms of biopsy proven improvement. So,
Yes,
and we know that coexistence of the C and the K, it is like in almost every two-third of the diabetic, they will have C plus K plus this part, the steatohepatitis
Metabolic.
part.
Yeah.
So definitely, and with the pockets of the patient, DAPA fits into everything, of course, and we have the data that there is improvement. So yes, it will be it is helpful for all of us.
Yes, absolutely. So again, and in fact, Dr. Ipsita, why there Dr. Shafi and Dr. Amrish Mittal's paper was very important, because they're the first time they had actually,
Absolutely.
nobody thought of that, right? Before that. So I think what we are now going to see is basically the culmination of what the chain they started, right? So I think it's again a proud moment for us as well.
But then
Yeah,
yes,
yes.
yes. But
No, no,
then
please go
what
ahead.
comes to my mind is SGLT2 inhibitors. Okay, if it is F2, it probably can come down. But beyond that, will it
Yes,
come down? So F3 and beyond. So I mean, though that this is good, but then I don't know because the population for our patients they are different. So maybe we should
right.
have something of our own.
Yes, yes. So they had small amount of about 20% with F3 fibrosis here also, and there
Right,
was
right.
improvement there also. But then when you're looking at higher grades of fibrosis, you are then really questioning of where you're really going, because then there are definitely challenges to that. So a little bit more on the trial. 45% of patients had type 2 diabetes. In fact, so I would say 55% did not have diabetes. 33% had F1, 45% have F2 fibrosis, and 19% have F3 fibrosis. Liver biopsy was done within 6 months before randomization. So that is a thing. And they found 53% MASH improvement without worsening of fibrosis, 23% MASH resolution without worsening of fibrosis, and 45% MASH improvement without worsening of MASH. So fibrosis improvement without worsening of MASH. So just remember this again. The audience needs to understand that when you're giving some of these therapies, some of the times, you have the inflammation which reduces, but the fibrosis worsens, and sometimes your fibrosis which reduces and inflammation worsens. That is what has happened with some of the earlier drugs. Now, the newer class of drugs, what they want is that both the inflammation should also reduce and fibrosis should also improve. So that is why you have more stringent criteria for looking at these drugs. Additionally, some of the biomarker endpoints like NAS scores also improved, right? Improvement in the steatosis, ballooning, inflammation in the biopsy parameters, and 3.5 kg weight loss was also seen with that. Overall, there was benefits in visceral fat, insulin resistance, lipid profile, blood pressure, which you all know the usual benefits of SGLT2 inhibitors. So, Dr. Ipsita, would you, after you know looking at this trial, would you consider giving SGLT2 inhibitor in your type 2 diabetic patients with MASH?
Of course, why not, sir?
Yeah,
Why
yeah,
not? This was the
yeah.
second patient, the first one which I spoke of, and another patient came to me today. He had got
Right.
IES like 33, 34 years old. As per him, he is non-alcoholic.
Right.
IFG, IGT, dyslipidemia is present. He didn't have a CBC, so I couldn't calculate a FIB4. But the
Right.
radiologist, whoever has done, they have done a VCT and they put a KPA of 9.1.
Right.
So,
So already has fibrosis. Yeah.
yes,
That's good. Yeah.
9.1. So, and then again, this patient also has got a BMI of around 24.5. So, again, I was like skeptical what to do, what to do, what to do. So, for this patient, definitely, I would like first have I've like, spoken about the part or need of a biopsy because whether what is the grade of fibrosis, that is something which would be rather interesting. And so I put him on dapagliflozin, and
Yeah.
let's
So
saying that let us see how it's behaving or not. It's,
yes.
so today only
Interesting.
two patients of massage.
Yes.
So
Yes. So, that illustrates that it's increasingly common, increasingly, looked at, and we see these patients in practice. So it's not that it's a theoretical construct. We do see patients like this in clinical practice, and it is important, right? So, yeah, one more thing I'll add, Dr. Ipsita, and about this entire area. We talked about the alcohol part. Some of the emerging data now with both GLP-1 and GLP-1 RA, the dual agonists, is that they have shown reduction in alcohol intake. So in fact, some of these patients would actually reduce their alcohol intake also, which could be an
yes,
additional benefit for the concept of MET ALD, that is, the MSLD with moderate to heavy alcohol intake. These patients, the alcohol intake would also probably come down, again, as a thought to that. So moving on, we'll talk about GLP-1 RA safety concerns. I'd actually originally put two studies here, but in the interest of time, we'll take one, which has been lot in news, and that is the risk with non-ischemic optic neuropathy, NAION. You had all heard about this. I think sometimes people hear about side effects more than they hear about the benefits also, but that is how usually we run. So this is, yeah. So this condition, came about a lot. It's been talked a lot about in recent times. That is non-arteritic ischemic optic neuropathy, which is called NAION, right? And the confusion really is that uh, there was one trial, one study, which showed that there was an increased risk of NAION. There were, episodes of this with GLP-1 RA per se, not just semaglutide. Then there was later on there was a paper published in JAMA Ophthalmology which showed that if you take a larger pool of patients, the risk is very low. And now, why this confusion? Because the trial which we're going to talk about is this one, which is just published in November 2025 in a slightly different journal. It's a journal of military medicine. So these are basically army veterans, and both the patients were veterans, and their the researchers were also veterans from army, from the US, and they actually found there was reduction in risk of non-ischemic optic neuropathy, right? So before we go to the study itself, Dr. Ipsita, your views on this topic, because it's an area of complete confusion right now, from one study showing increase, one study showing neutral, and the other study now showing a reduced risk of and of course there is going to be a dedicated trial from semaglutide from Novo Nordisk soon, which will clarify all these problems. But before that, what's your view on this?
honestly, after going through this data, I myself, I was very confused. I mean, I am as such confused really with this part. So yes, the concept of NION came up in 2024, a large data from US, and then there were another small data from the Danish population. But then there was
Yes.
a very beautiful editorial by Abdesh sir, which was published in JAPI, where he said that you cannot say that everything is attributed to the GLP-1 analogs per se. Of course, the concept is somewhat similar to the evolution of insulin neuritis, which we had read much earlier. That
Yes.
if you
Yes.
rapidly want to bring down the glycemic parameters, then the perfusion part gets there is a change in the perfusion at that point, especially in the small vessels supplying the optic nerve. And we knew that there could be worsening of a pre-existing DR, PDR, and this. So
Which
basically,
is well
that is
known.
the basic
Correct.
pathogenesis. So I
Right.
do believe is that we, even if there is a plus and a minus and a protective data out here which is published. So whenever we want to plan any GLP-1 analogs therapies, of course, the eyes need to be screened. And now the
Right.
data is, we are going to have a trial is going on with GLP-1 analogs in patients who are having PDR. So that will
Right.
also be published soon. So yes, the rate of reduction of the glycemic parameters should be in a controlled fashion if we are planning to use. So a pre-existing optic neuritis or a pre-existing NAION, until and unless you get a large amount of data, you should be cautious. And this trial showed that even in patients, I think they had a subgroup analysis with the PDE5s.
Yes.
PD5s are
Yes.
also known to have worsening of,
Produce similar. Correct. Correct.
yes, NAION. So again, they didn't find any correlation. I do not know what was the causal mechanism, but it is the finding from this data. To my, if somebody asks me, if a patient has got a pre-existing PDR or a pre-existing ON, then I will avoid using these group of molecules at the first go to see further what is going to happen or not going to happen. And then if some, or if the, I mean, the benefits are outweighing the risks, then go for a very slow kind of a glycemic control where
Right.
this mechanism of can be taken care of.
Very true. So let me reiterate the point what Dr. Ipsita very rightly said. One of the thought mechanisms thought of is that, the blood vessels supplying these optic nerves is the one, if there's a rapid change there, there could be rapid flux and that could probably lead to ischemia. That is the mechanism which has been thought. So if it is slowed down, you're very right. It's a very interesting idea. Just like in type 1 diabetes or, in a diabetic patient, where if the rate of the glycemic correction is slower, then they don't develop these complications. But if there's a rapid change in, improvement in glycemic control, there is sometimes, triggering of these mechanisms. So the same could hold true for these class of drug. Now, why it's important for GLP and why it kind of gets triggered with GLP is because, GLP receptor agonists rapidly reduce the blood sugars, right? There's a rapid improvement in glycemic control. And because of that, it could trigger these events. So hence probably, where you have increased risk, maybe go slow, and that could be one way of looking at it. But at least what is interesting here is that the trial does say, I mean, we're not sure about improvement, but at least if you see this, because they took huge number of patients, right? They took lots of patients, and looking at this huge number, and they took obese diabetic patients as well as non-diabetic patients. So I think overall, if you see, it's quite reassuring that at least, the increased risk when a lot of our patients are concerned, that is actually not there. So some and it was a retrospective study. They just took, the data from the military health data system. It was a large data set. They took diabetic obese patients from that. There were events of NAION also reported. Uh, and they also looked at subset which Dr. Ipsita said, with the use of sildenafil and PDE5 inhibitors, tadalafil and sildenafil, because they have also been known to produce these kind of side effects, right? But overall, if you saw, there were actually 0.36 odds ratio. There's 64% lower risk of developing NAION with semaglutide. Very interesting. And same with the obese subset also. Uh, so overall, it basically contradicts the single center study which shows increased risk. So I think for sure, the increased risk thing is probably, we not should be so much worried about it. Uh, Whether semaglutide is protective of NAION, we don't know. But again, if you talk with some of the non-Audis people also, they were initially saying that, you know, uh, there were some data where they actually shown protective mechanisms. So they were also very confused with, the initial data which came. You require basically what you require is a good trial, right? And which you're, luckily going to have that, the results soon. So we'll know what it is. And like Dr. Ipsita said, we don't know the potential cause is not very clear. But the benefits in these patients could be because of the improvement in glycemic control, which could also have a positive impact there. So, but as of now, we are not very sure about this. Whether you should be changing, of course, this is practice changing updates, whether you should be changing your practice as a result of this study. I'm not sure, but at least at the same time, what I'll say is that it is practice changing from a point of view that's quite reassuring, especially when you tell your patients that now there's a recent study where there is actually protection from these things. At least, for your patient, it's pretty reassuring, especially those who are worried about and hear about all this on social media. Dr. Ipsita, before we move, your final concluding remarks on this topic. Anything you want to add?
Yes, what I think what this slide which has shown us that yes, the baseline and follow-up of the part is something which is important, and we should have informed consent related to this part. So
Right.
we can prescribe continued GLP-1 RAs, but then with the data that is there, it is whatever is there. It is with I mean plus minus it was there with SEMA, so with caution, of course, because at this point of time also I am not very sure. Maybe focus which comes up, which is ongoing by 2027, we get the data. If that gives good results, yes, there will be no problem. But then with with caution, with I mean it has to be guarded.
Yes, absolutely. Finally, let's move to the last topic of the discussion today, and that's the perioperative use of SGLT2 inhibitors in diabetes management. And for the longest time, in fact, there is now current guideline also stands that if your patient is about to undergo surgery, you have to stop SGLT2 inhibitors 3 days before the surgery, because there are again concerns about euglycemic ketoacidosis and renal risks, like for example acute kidney injury and so on. So there are these concerns about use of SGLT2 inhibitors before surgery. And very interestingly, there's a recent trial which is now challenging this notion, right? So this is the last paper today which we're going to discuss, and that's the study which was published in JAMA Surgery in June 2025, which is basically a large study of perioperative use of SGLT2 inhibitors. So they took about this huge number of patients again from the VA health system. Again, a common theme that these VA and military systems actually have very good database, which is I think something which we should all think of, because they are doing so beautiful trials, very useful trials, useful important studies which are practice changing because they have very good data set. There were 7,000 patients on SGLT2 inhibitors, and their propensity matched with the those who were not. And they was basically wanted to see is that perioperative SGLT2 use, was it linked with euglycemic ketoacidosis and acute kidney injury or mortality? So that is what they looked at. Dr. Ipsita, what's your general practice in terms of SGLT2 use perioperatively as of now?
So as of now, we were for still go by the US FDA guideline of that you
Right.
have to stop it 72 hours before the any kind of a surgery, elective if at all. And if it is an emergency where the patient is already on, the effect of the SGLT2 can stay for 48 hours. But then
Right.
this data which came up this year, it rather it showed a protective effect that you should not discontinue, because the cardiac and the renal part is something which needs to be still preserved, and there is no more of onset of an AKI or the euglycemic DKA. So with if at all a patient is on SGLT2 inhibitor, the only risk concern where we think of a euglycemic DKA, then we know understand that how euglycemic DKA probably operates when SGLT2 inhibitors are given. So we can take care of the kind of the if it is an elective surgery, yes, take care of the last meal, maybe a small dose of insulin which will take care of the ketosis if at all it will be going on, or if the patient is likely to go on. But then what I feel is that we should try to understand, or there should be a kind of a model to understand that what would be the predictive factors, if at all, if a patient
Right.
is on SGLT2 inhibitor, what would be
Mhm.
the predictive factors to calculate that this patient may go to DKA if we
Correct.
continue the SGLT2 inhibitors?
Very true, which is very interesting. So, if you could predict which patients are likely to develop a euglycemic ketosis, you would probably not continue SGLT2. For the others, you probably would continue SGLT2 inhibitors, which is a very interesting point. Maybe a sub-analysis of their own, because they have a huge number here. So maybe a sub-analysis there would be interesting. Let me just first tell you the trial results, the study results. Uh, so there was increased risk of euglycemic ketosis, right? Which is not surprising because again, uh, that this happens, right? So there's 1.1 odds ratio of euglycemic ketosis But interestingly, there was 31% reduction of acute kidney injury, and there was actually an improvement in mortality. So 30-day mortality rate was improved. So there was 30% reduction in the deaths perioperatively, which is again, so I mean, end of the day, if less patients are dying, I mean, what better could it be, right? So overall, if you see, there was benefit, except for that again statistical significant increased risk of euglycemic ketosis. So there was increased risk without a doubt, and this was statistically significant. But you have to then weigh it in the context of the other benefits that you are seeing. Uh, it does question, and I think I completely agree with what you said, Dr. Ipsita, that I think the idea here is then that you separate these two outs. Which are the patients where continuing SGLT2 inhibitor is going to have benefit versus which are the patients where you could have harm. It's a very good idea. Maybe look at, maybe we could dissect this study itself and publish some sort of a maybe a letter to editor at least, if not anything. It could work out, but it's a great idea. Anything else you want to add, Dr. Ipsita, to this particular study?
This is a thing which came to my mind, that how can we predict it, this related part. And sometimes honestly I feel that it is nothing. I mean, we are following evidence based depending upon the statistics part. So these are the
Right.
mathematical equations, and we get the ORs and the HRs and the RRs and the ARs, and then okay, we are happy with the numbers. But if
Yeah.
everything which comes up, science has got no limit, what I feel. So, and sometimes my brain goes in, slips into some questions
Yeah.
where I also don't get answers. So,
Yeah.
yes,
But
this is the
it's a great question to answer, that which are the patients where you could continue SGLT2 and which are the patients you could not. I think we could find results there, but you're very right. But I think at least for the practice changing part, I think what I feel is, at least for the patients where who are on SGLT2 continuing to have benefit, who do not have prior episodes of euglycemic ketosis recorded, uh, you know probably it would not be a bad idea of continuing perioperative SGLT2. But the patient where you are expecting high amount of volume loss, blood loss, complicated surgeries,
yes.
again prior histories of poor having poor glycemic control, having requiring insulin, having sort of beta cell dysfunction, maybe in these groups who probably will not give SGLT2. So I
Yes.
think, or continue SGLT2. So I think at least from
Yes.
a pragmatic perspective, you could look at, yes,
No, the
you
thing
see.
is that if somebody is on and if it's an emergency surgery, we can be
Yeah,
cautious and we should not
correct,
panic out there. But
correct.
yes,
So
in the elective ones, as you said, that these small questions of the whether it is the degree of involvement of blood, volume loss, prior history, everything, there you need to be guarded again.
yes, very true. So I think overall, the approach should be that, at least it's again very reassuring here as well. Again, so these are practicing, because sometimes it is very assuring for us also. The non-ischemic optic neuropathy, and even this paper here, that if the patient does require to if that has been continued, it's an emergency surgery, somebody continues an SGLT2, we don't need to worry and panic about it, and probably might look at this from a perspective that it could be actually beneficial. So let me then summarize the four areas which we discussed today. All very interesting, and Dr. Ipsita, gave some very interesting insights, which I think gets my mind also thinking. Something very interesting ideas. Type 1 diabetes and obesity. There is now potential use of semaglutide and tirzapatide. Maybe look at this carefully. Look at this space. Maybe we'll find more evolution of data on this topic. Now that you have very good initial a use case here. MSLD is changing now, because now you have multiple drugs which are approved for MSLD at the same time, especially semaglutide with the Essence trial has got approval. But Dapagliflozin or SGLT2 inhibitors still could be your go-to drug, especially in your diabetic patient with MSLD. But here they actually showed non-diabetic patient also may have benefit, so that's something we should look at. Uh, the non-ischemic optic neuropathy is an interesting idea, right? And there's a recent study which is quite reassuring, saying that actually it reduces the risk of non-ischemic optic neuropathy. We don't know about the reduction of risk part, but at least the high risk part is the causation part is actually, I think, now well thought of, and now we are going to have a established study soon in a few years time. And finally, perioperative use of SGLT2 inhibitor, the usual notion of compulsory stopping it all for all patients 72 hours before surgery may be challenged because of this new data, and maybe again look at this paper more carefully. We could probably find more insights into that. For those who are new to this, we have put all these full text articles of these papers on technochronology.com, so you can have a look. The discussion which we had right now, and also the presentation which is there in front of you, all of them would be put up on technochronology.com. So you can go there, look at the YEARMED 2025, and explore all the data. If you missed any of the previous episodes also, you can go back and have a look at that. So with this, it concludes our series. Dr. Ipsita, thank you so much. It was wonderful discussing this with you. Some great insights, especially I mean this uh, selecting which patients will benefit from SGLT2 is something very interesting. I think if you look at this paper, I'll actually relook at this, because if there is some insight there itself, there could be a potential publication also, and something very interesting. So thank you for
Thank you
this
so much
wonderful
for
insight.
having me here.
Thank you, and thank you once again to Lupin Azario division. I think they were very gracious with this. It was a complete, as said earlier, this was a complete free editorial freedom. There was no editorial interference to the any of the papers, and completely seamless educational grant in a sense for this project of ours of EOMED, trying to give you updates of what developed over the year, so that you could have a good bird's eye view of the overall field which we are all practicing. So thank you, Dr. Ipsita, once again, and hope to see you soon, and have a great Sunday tomorrow, and thank you for spending your Saturday night on this, and yeah, thank you so much. Good night.
Thank you. See you soon somewhere.
See you. Bye. Good night.
Bye.